Hello, my name is Jasmine Lee Hill, and I'm a nurse clinician in advanced practice for the surgical department at the Royal Victoria Hospital. And today I will be presenting the third module on tracheostomy care. By the end of this lecture, you'll be able to list the indications of a tracheostomy. You'll be able to recognize the different types of tracheostomy tubes. You'll be able to assess the integrity of the pilot balloon and perform tracheostomy daily nursing care. So why a tracheostomy? We'll first start with what is a tracheostomy. It's a surgical opening created in the trachea. And why does someone get a tracheostomy? It's for several reasons. The first one is to bypass an obstruction in the upper airway, and this can be caused by a laryngeal or craniofacial tumor, tracheal malacia, tracheal stenosis, or compression of an airway by a large vessel. You can also get a tracheostomy to maintain a patent airway in the presence of severe injury or upper airway procedures. So this can happen when you're having surgery and you're expecting a lot of swelling in the area. Also for trauma, burns, facial fractures, upper airway trauma, neoplasms, also for abnormal supraglottic and glottic pathologies. Also if there's a foreign body trapped in the upper airway. The third reason why you could have a tracheostomy is to protect the airway in presence of absent airway protective responses. So this you can see if there's a bilateral vocal cord paralysis, an inability for someone to cough adequately or swallow adequately to clear their secretions to maintain a patent upper airway. And finally, it's to assist with long-term ventilation. So this could be due to pulmonary disease, congenital heart disease, or neurological neuromuscular diseases. So this is the typical journey of a patient with a tracheostomy tube here at the hospital. This is one we see the most frequent, although I would say there's 3 different types of journeys. So the most common one happens, the patient will have a tracheostomy tube inserted. We perform the initial management, which happens usually in a critical care setting. They then can usually progress to a speaking valve, then hopefully a corking trial where we basically put a cap on top of the tracheostomy tube to block it. And then if they pass their corking trial, then we can hopefully decannulate the tracheostomy tube, which means to remove the whole thing. That's our usual journey we see. There's also the journey where we already know this patient is going to be a long-term tracheostomy patient, so we don't go to the corking trial and we don't end up decannulating them. They will actually be discharged with their tracheostomy tube. And the third trajectory is a long-term trach patient who requires home ventilation or ventilation in an institution. So we have different types of tracheostomy tubes here in the hospital. We have cuffed and cuffless. So a cuffed tracheostomy tube, you'll see a pilot balloon and you'll see a balloon on the outer diameter of the tracheostomy tube. They come in disposable inner cannulas or reusable inner cannulas. And how you tell the difference, and I'll get to that on my next slide, is on the trach plate, you will see a code. If the letter ends in A or H, it means the inner cannula is disposable. If the letter ends in R, it means reusable, and that's fairly easy to remember. You also have the sizes on the trach plates. You have 4, 6, and 8. And the smaller number usually means the smaller diameter of the tracheostomy tube. So we also have, like I said, the cuff and the cuffless, and the cuffless is without the balloon, which you'll see in the next slide. So what type of tube? So it's how you see the type of tube is you check on the tracheostomy plate, and you'll notice there are a couple of numbers and letters there. The first number is the size of your tracheostomy tube. So on the slide here, you'll see that there's number 8. So your tracheostomy tube is a size number 8. The next letters you see are either UN for an uncuffed trach or CN for a cuffed trach. The next numbers you'll see is 8.5, some have 7.5. That's basically the inner diameter of the outer cannula. Not a number you need to focus on so much. It's really the first number, the 8 that I mentioned, that you will need to really understand because that's the inner cannula that will fit. And finally, the last letter is R for reusable. And if it's a disposable tracheostomy tube, it will end in A or H. So this is all displayed on the tracheostomy plate. Another quick reminder too is that if you see the colored box on the tracheostomy plate, That also indicates it's a disposable inner cannula because they're all color coded. So if I have a navy blue box on my trach plate, I know that I need to go get an inner cannula from the navy blue box in the nursing station. If there's no colored box, that usually means it's a reusable, because you're not supposed to be changing that inner cannula. You're supposed to be taking it out, cleaning it, and putting the same one back in. And you can see all these reference codes displayed on the bottom portion of the slide. These are all shown on the boxes of the tracheostomy tubes. So we're going to talk a little bit more about cuffed and cuffless tracheostomy tubes. So a cuffed tracheostomy tube, so that you'll see the soft balloon around the distal end of the tube that inflates to seal the airway. You can tell the inner balloon is inflated sufficiently when you don't hear a leak around the patient's neck and the pilot balloon is inflated. So you can just test the pilot balloon on the outer part of the tracheostomy tube between your fingers, and that's a subjective sign that the balloon inside, which you won't see, it's on the tube inside the patient, is also inflated. So you'll see the pilot balloon, the flange, the outer cannula, the cuff, which is the balloon inside the trach that you won't see, and also the inner cannula. All of these tracheostomy tubes also have an obturator. So this is basically used only for the insertion of a tracheostomy tube. It has a smooth, round, blunt tip and protects against mucosal damage on the insertion of a tracheostomy tube. So what happens is they take out the inner cannula, put the obturator in when they're inserting the tracheostomy tube. Once they've inserted the tracheostomy tube, they remove the obturator right away and put the inner cannula in place. Pretty much all patients will start off with a cuffed tracheostomy tube on initial insertion, and that's mostly because they will need mechanical ventilation or they've required some type of surgery, because this is usually done in an emergency situation. So we'll talk a little bit more about the cuff tube and inflated cuff versus a deflated cuff. So you'll see on the image the inflated cuff. So this provides ventilation without air leaks because it provides a nice seal so the patient can be oxygenated properly. It's needed for mechanical ventilation. You have to have a cuff inflated for proper mechanical ventilation. It prevents gross aspiration and pharyngeal and gastric secretions. However, it does not prevent all aspiration. So if your cuff is inflated and your patient vomits and they aspirate the vomit will still sit on the cuff. So they haven't had a gross aspiration, but technically they've still aspirated that vomit because it's gone past the level of the pharynx and the larynx. And so to get that out, you can slowly deflate the cuff while suctioning the patient simultaneously. However, there will always still be a bit of aspiration that's happening. So that's with your inflated cuff. For your deflated cuff, so this allows the patient to talk and eat, and drink. It also prevents ulceration of the trachea by allowing relief from the pressure that's imposed on the tracheal walls by the balloon. So if you always have the balloon inflated, you can imagine the pressure that's created from that. And as per the American Thoracic Society, it's recommended to suction the patient orally before deflating the balloon to prevent nosocomial infection, because you have the flora that can accumulate in the mouth above the balloon. And the cuff should always be deflated at all times, except in the following situations. If you're mechanically ventilated, of course it needs to be inflated, or in the event that you see sudden bright red blood coming from the tracheostomy tube, you can inflate the cuff. So the pilot balloon, as I mentioned, you can see on the outer cannula. The purpose of the pilot balloon is to show that the cuff is sufficiently inflated. So again, the cuff being the balloon inside the patient that we can't visually see. So you feeling the soft pressure within the fingers, again, is a subjective sign that the cuff is not overinflated. When the cuff pressure is inadequate, you have oral pharyngeal secretions that can leak around the cuff, increasing your risk of ventilatory associated pneumonias. So for the cuff care, this is checked regularly using a cuff pressure manometer to ensure it is adequately inflated, and this is usually performed by the respiratory therapist. It also prevents injury and necrosis from overinflation. So We need to make sure that the cuff is properly inflated. If it becomes overly inflated, we're just putting more pressure on the tracheal walls, and this can cause necrosis. And again, inadequate cuff pressure increases the risk of ventilatory associated pneumonias, because you can have leakage of the secretions around going into the patient's lungs. A cuffless tracheostomy tube. So I just talked about the cuff tracheostomy tube, and now the cuffless tracheostomy tube. So you'll notice on this tracheostomy tube, there is no pilot balloon and there is no cuff around the outer cannula. Why does a patient need a cuffless tracheostomy tube? So it's basically for patients who are able to breathe on their own and don't require any mechanical ventilation. The patient has to require an effective gag and cough reflex to prevent him or her from aspiration. It is also a safety reason why we change patients to a cuffless tracheostomy tube. So if they're going to one of the units and they don't require mechanical ventilation, we will change them to a cuffless tube, because secretions can tend to accumulate around the cuff in the trach, even if it's deflated, which increases the patient's risk of occluding and blocking their airway. So that was the cuff and cuffless. We also, in each of these, the cuff and cuffless, we have inner cannulas that are either disposable or reusable. In the hospital, we usually use disposable inner cannulas for infectious control reasons, and it also decreases the amount of nursing time spent doing the care. When a patient is discharged home, that's when we change it to a reusable inner cannula. So the whole trach has to be changed for one that has a reusable inner cannula. And that's for cost reasons. It can be very costly for the patient, who has to do it at a minimum twice a day. Otherwise, everyone else will have a disposable inner cannula. So those are your regular Shiley trachs. We also have extended length tracheostomy tubes. So these tubes are a bit longer in length. One of the reasons a patient might need an extended length trach tube is they need a proximal extension, so meaning they need the tracheostomy tube to be longer proximally, and this is for patients who have a large neck or increased fatty tissue around the neck, so our obese population. We also have tracheostomy tubes that are distal, so they have an extended length on the distal portion of the trach tube, and this is usually put in for patients who have a mass, let's say a tumor lower, and they need to bypass that to actually get into the airway, or stenosis. Some important things to remember, so this also does come in cuff and cuffless, so they do have those options. The inner cannula, however, for this is always disposable. It's not made in a reusable inner cannula. However, we can order specially particular trach tubes that are extended length with a reusable inner cannula if need be. So some fenestrated tubes, we don't see them very frequently here at the MUHC anymore. But these fenestrated tubes, basically it's an opening in the tube. It can be single or it can be multiple. It allows the air to pass through. It allows for easier air passage to the larynx, which allows for phonation. So if there's more air going up towards the upper airway, it passes their vocal cords, which is located above the level of your tracheostomy tube, which allows them to phonate. It requires a non-fenestrated inner cannula for suctioning. So you can't suction a patient with a fenestrated tube with their fenestrated inner cannula in place. And the reason being is that your suction catheter could go through the little holes at the back wall and actually cause trauma to the back wall of your trachea. So you have to take that inner cannula out, replace it with a regular inner cannula so that you can suction the patient adequately. Some pediatric specifics. So in children under the age of a year, the tracheal diameter is very small. So therefore, a cuffed, a fenestrated, and inner cannulas are rarely used because they need to be replaced every time the child grows. So some criteria for selection for an uncuffed tracheostomy tube. So between 12 and 18 months, you're going to use a 4.0 pediatric one. Between 18 months to 3 years, it's going to be 4.5 to 5.0 pediatric. 3 to 6 years old is going to be probably about a 5.0 pediatric. And then, of course, as they grow, then they will grow into the adult sizes that I had just mentioned before. It's important to note that because these particular inner cannulas in the pediatric population do not have an inner cannula, to ensure the permeability and to make sure that the airway is patent, they are required to suction the infant at least one time in the morning and once in the evening, so twice a day. Whereas for us in the adult population, we can just take out the inner cannula and see that the inner cannula is patent. It's also important to be mindful that as a child develops, obviously their diameter of the trachea gradually enlarges. That will cause air leaks around the tracheostomy, despite the presence of a balloon. So if their cuff is inflated, if you start to hear an air leak or air around, that should be a signal that maybe this child needs their trach to be a larger size. And generally, adolescents over 12 years old and adults who have reached their maximum physical development don't require replacement of the inner cannula for a change inside. They will just require their usual changing of the tracheostomy tube. So some basic observations. So when you walk into your patient's room, it's very important for you to do all your checks. So when you walk in your patient's room, it's important for you to understand, why does the patient have this tracheostomy tube? Is it because of a tumor? Is it because of surgery and the anticipated swelling? When was this tracheostomy tube inserted? That's important because most tracheostomy tubes for the first 7 days will be sutured to the skin. And that's to prevent if there's any accidental decannulation, the tracheostoma is not well formed enough and will close very rapidly. So for the most part, not all, but for the most part, they will be sutured to the skin to avoid that for the first 7 days. And then your tracheostomy tube can be changed after the fact. What type of tube are you dealing with? You need to know what size it is, because you need to know what type of inner cannulas you need to get ready at the bedside and to perform your care. Is it a disposable inner cannula? Is it a reusable? Is it a cuffed or cuffless tracheostomy tube? These are important things to remember. If it's a patient who doesn't require mechanical ventilation and arrives on your unit, it's important for you to question if there's still a cuffed tracheostomy tube in place, because it might be time to change it to a cuffless, and that's something you should speak to the physicians about. So again, the pilot balloon, if there is one that's necessary, if this patient is being mechanically ventilated, is it inflated adequately? Again, if they get to your unit and it's there, it's good to question why. Tracheostomy ties, are they secure? Is there 2 finger space allowed between the neck and the tracheostomy ties? Is it on tightly enough? Your supportive equipment, is it working properly? You want to make sure that all your suctions set up and functioning, that your oxygen is set up and functioning as well. Last thing you want to do is run around for a suction catheter when your patient needs their airway cleared. Ventilator alarms should be turned on and should be audible. Your ventilator tubing. One important thing to keep in mind is that when you're transferring a resident to the bed, it can cause respiratory distress. So to have a manual resuscitation bag readily available to assist with ventilation is useful if needed. And it's also important for you to trace the ventilator tubing from the patient to the point of origin. So to make sure that all connections are secure to prevent any dangerous disconnections that might happen during transfer. Of course, you want to take your vital signs, your respiratory assessment, your respiratory rates, your oxygen saturation, the secretions. You want to see if the patient has secretions, small amount, moderate amount, large amount. What do they look like? Are they thick? Are they thin? The color of the secretions. Is this patient able to cough by themselves? Do they have a good cough reflex? Are they able to clear their own secretions themselves by coughing? Or is this someone who has an absent cough reflex? And that would mean that you would need to go and suction these patients probably more frequently. Any signs and symptoms of infection, so not just respiratory-wise in terms of your secretions, you want to check for signs and symptoms of infection there, but also around your tracheostoma site to make sure that your site is nice and intact. And the ability to swallow. We want to see if these patients have had a swallowing test by the speech-language pathologist or the occupational therapist. Because you have a tracheostomy tube, it doesn't mean that you will automatically fail your swallowing test. So it's good for you to know, does my patient, have they had a swallowing test? Did they pass? Yes. That means they're allowed to probably eat orally. And if they failed, it's important for you to know as well, because they will not be allowed to eat orally. Some hands-off communication. So when you're giving a report to the next nurse who's caring for this patient with a tracheostomy tube, it's important to use the SBAR method. So your situation, your background, your assessment, and your recommendation. So you want to explain what the reason is for the tracheostomy tube. You want to explain the current ventilatory modes and settings, so including fraction of inspired oxygen, tidal volume or pressure level, the rate, inspiratory flow and flow waveform, inspiratory time, sensitivity, and positive end expiratory pressure if it's ordered. It's also important for you to relay the information of what type of tracheostomy tube it is, the size, if it's an extended length, if it's a regular, disposable, reusable inner cannulas. And then you want to go into your background. So the diagnosis of this patient, what's the history of this patient, then into your assessment, what were your vital signs, any respiratory assessment findings, including your breath sounds, respiratory rate, their effort as well, and sputum production and characteristics, as well as their level of consciousness. Also, the condition of the tracheostomy site. So how is the tracheostoma? Is it the skin intact? Is there any pressure injury around the site? What does it look like? And finally, your recommendations. So your follow-up, any concerns, the frequency of suction that needs to happen, any dressing changes. And finally, if the patient's weaning protocol or tolerance of weaning, if the patient is weaning from a mechanical ventilator. So again, just some emergency readiness. So also when you're going in to check your patients, like you did all the checks before, it's important for you to go into your room and make sure all your equipment and all the material you need is at the bedside, because the last thing you want to do in an emergency situation is start running around looking for things. So when you first get your patient, it's important for you to make sure that all these things are available in the room for you. The oxygen is set up and functioning. They have high humidity therapy, because all trach patients should have a high humidity in place. Suction equipment, it's connected and it's functioning. Scissors in case for the cotton ties, when you have to take off the cotton ties. Although most people have the Velcro ties, which I would encourage you to use. NS or sterile water. Ambu bag inside the room, and a 10 milliliter syringe, and this is mostly only if your patient is intubated or is ventilated. Lubricant and gauze, 4x4 gauze for the cleaning. An extra inner cannula is very important to have in case your inner cannula blocks. You can quickly take it out. Now you have a patent airway, and put a nice clean inner cannula in place, and it's at the bedside ready for you. Finally, you need to make sure that you have additional tracheostomy tube boxes or sets at the bedside, or in a location that you know they're there and close by. So you need one that's the same size as the patient's current tube. So if my patient has a size 6, I need to make sure that a size 6 box is readily available, and one size smaller. So again, so if my patient has a size 6, you need to also make sure a size 4 is at the bedside, because it is possible that if they have an accidental decannulation and the RT comes to put in the size 6 and it no longer fits, at least you have the size 4 also readily available there for you. So how to protect myself? So infection control precautions. I will say this changes very, very, very frequently. So I'm only giving the update as it stands now. However, I would encourage you to go on the intranet and check the policies, because it's very fluid. It changes depending on the waves we're in of COVID-19. So as it stands now, this is what it is. Most patients in the hospital, like I said, will have a disposable inner cannula. Again, that for COVID-19 reasons, it decreases the amount of time that the nurses spend at the bedside in direct contact with the tracheostomy tube. And the routine changes. So if a patient comes into the hospital with a reusable trach tube, because again, if you remember, in the community, they will have a reusable trach tube. When they come into the hospital, we won't automatically change them to a disposable. We will keep the reusable until the time that they need it changed. So we try to reduce the amount of complete tracheostomy tube changes, because that is an aerosol generating procedure where we have to gown everything up. So we will just keep with our routine changes. So again, as mentioned, obviously if you're COVID-19, you have to wear everything, the N95, the visor, the gown. It's recommended to have a negative pressure room, but if one's not available, at least have the door closed. However, if you're a patient who's asymptomatic, COVID-19 negative, non-suspected, non-quarantined, non-exposed, you only need the N95 and the face shield and the gown for a decannulation, so when we take the entire trach tube out, for a tracheostomy tube change, so when we change the tube for a new one. All the other things that you'll see you need an N95 for the high flow humidity, when we're applying or removing speaking valves, removing corks, open suctioning, you only need to protect yourself with the N95 for the first 10 days. After the 10th day, on the 11th day, if the patient still remains asymptomatic, non-suspected, non-quarantined, non-exposed, and is still negative for COVID-19, then you can go to your regular face mask. But again, I would encourage you to check on the website continuously, as this changes quite often. So tracheostomy nursing care. So right now I'll speak about the daily nursing care that you're going to be performing with your patients. So it consists of suctioning, tracheostoma cleaning, cleaning the inner cannula or changing the inner cannula if you have a disposable one, changing the neckties, and mouth care, which is very, very important. We tend to forget, the patients tend to forget as well. It's important to continue to encourage them to brush their teeth, rinse out their mouth, and so forth. And if they can't do it themselves, that we should be doing it for them. High humidity trach collar must be worn at all times, and even with a speaking valve. So the reason is, with your tracheostomy patients, they're bypassing their upper airways, so the mouth and nose, which provides filtration and humidification for the air we breathe. So when they have a tracheostomy tube, the air is quite dry and quite cool, and their secretions can tend to get thicker and harder to bring up. So we need to provide them with a bit of humidity. And that's why we recommend that for all your tracheostomy patients, they should wear the high humidity trach collar at all times, because they're bypassing their nose and their mouth. And why do you wear it even with a speaking valve? Is because a speaking valve is a one-way valve. So if I have a speaking valve on, when I inhale, I'm still inhaling through the tracheostomy tube, which means I'm still not getting the humidification from above. So the patients will still need to wear their high humidity trach collar. And tracheostomy care should always be sterile within a hospital setting. At home, they do use a clean technique. However, when they step into the hospital, we should maintain as a sterile technique as much as possible. Suctioning. So suctioning is a very stressful event and experience for patients. For some people, it can cause pain. It can cause a choking sensation. We're basically taking the air out of their lungs, so it's not a comfortable feeling. It's important for you to explain the procedure even when the patient is unconscious, because they still have their hearing. When do we perform suctioning? It's as a PRN basis only, and not on a regular basis. And the frequency of suctioning depends on multiple factors. So if you have a patient who has a good cough reflex and a strong enough cough and is able to cough out their own secretions, there's no need for you to go down and suction this patient. They can clear their own airway. If you have a patient who does not have a strong cough, and you hear the gurgling and you do your respiratory assessment and you listen to the lungs and it sounds wet, then that's the type of patient you're probably going to need to suction a little more often. So some indications for suctioning. So why do we have to suction a patient? If there's discomfort, when you see restlessness or agitation, sometimes I find that's the first signal. Altered level of consciousness, a gradual or sudden drop in oxygen saturation, unable to remove secretions on their own, like I was mentioning before about the having a weak cough. If you hear rhonchi sounds, visible secretions in the airway, so if you see a lot of secretions coming out of the tracheostomy tube. If you need to obtain a sputum culture, you will need to go in and suction the patient to obtain a clean sputum culture. And if you have high alarm sounds indicating there's a rise in pressure. Also, if the patient states they need to be suctioned, it's probably a good indication. You could always encourage them to try and cough it out themselves, but if they still can't clear it, then we will need to go in and suction the patient. So shallow versus deep suctioning. So shallow suctioning, a patient is able to cough up the secretions themselves, like I mentioned. You're able to see the secretions that just came out of the tracheostomy tube, and you can yank or suction the secretions away from the patient. The deep suctioning is what I meant by you're actually inserting the suction catheter into the tracheostomy tube. This is usually for patients who have a poor cough reflex. The mucus cannot be cleared from the airway themselves. They're in respiratory distress. So what you would do with these types of patients is you would take your suction catheter, insert the suction catheter into the trachea, just about a centimeter above the carina, press your suction and pull out to clear out the airway. Of course, if you're unable to clear the secretions and the patient's in respiratory distress, remove your inner cannula to see if there's something blocking the inner cannula and to reassess your patient. And you should always follow the tracheostomy emergency algorithm, which is available on the intranet. And I would suggest you look at the algorithm at the beginning of your shift or before you have your tracheostomy tube patient, because when you're in the emergency situation, you're not going to go run to find the algorithm. So it's a good idea just to be aware of what you need to do. So suctioning a patient with an open circuit who's not ventilated. So here are some tips. Usually we recommend you can pre-oxygenate the patient. This is not necessarily for everyone. If you know your patient desats during suctioning episodes, then we would recommend you pre-oxygenate your patient. And all you would need to do is increase the level of oxygen by 10%. So most of these patients are on the high humidity at 28%. You would just need to turn it to the next level, which is 35%. And you can leave that on for 2 minutes before you're suctioning. The inner cannula must always be present when you're suctioning a patient. And the reason for that is if you take out your inner cannula and I suction my patient and I get a big mucus plug and I'm trying to pull out this mucus plug with my suction catheter and I can't, it gets stuck in the outer cannula. I've lost my safety mechanism of just pulling out that inner cannula to ensure that the patient can breathe again. So I always suction with my inner cannula present for that exact reason. If I'm suctioning, I pull out a big mucus plug, it gets stuck in the cannula and I can't suction it out, I can just take out my inner cannula and the mucus plug should be there and the patient can breathe and I can change my inner cannula. So it's a safety mechanism. Suctioning should usually be done before your tracheostomy care, just so that you clear the airway and clear everything so that you don't have secretions all over the place when you're trying to clean around the site and so forth. We usually recommend a suction catheter size 12 to 14. It actually should be double the size of your tracheostomy tube. So if I have a size 6, I should go with a size 12 suction catheter. The reason we don't use a yanker is because we see a lot of cross-contamination. So we have someone using a yanker, they put it in their mouth, the same yanker, they put it back into the trach tube and vice versa. And so they're just cross-contaminating all the bacteria. You can use a yanker if you want, but have one separate for the tracheostomy tube and the other one for mouth care. The wall suction gauge, usually adults, we recommend between 80 and 120, max 150. In infants and children, it's 60 to 100. So what we would do is we would insert the suction catheter without putting the suction on. So you insert the suction catheter until the patient coughs or until you meet resistance. You then pull back a little bit, about 1 centimeter, apply your suction, and twirl out of the tracheostomy tube and suction your patient. We recommend suctioning no longer than 10 seconds at a time. And if you think about it, 10 seconds is quite a long time. If you 1, 2, 3, and all the while you're suctioning all the air out of the patient's lungs. So tends to be shorter than that, but 10 seconds max. And we use continuous suction when we pull back on the catheter. I know some people have been taught intermittent suction, but here we use continuous. It's a much more effective, efficient way to suction your patient, and it does not cause more harm. So the reason we don't use intermittent suction, if I'm going in with the suction catheter, I'm pulling out a bunch of secretions. As soon as I let off the pressure of the suction, the secretions fall back down and it's just an inefficient way to suction the patient. So we do recommend the continuous suctioning. And the amount of times you have to suction, there's no limit. You need to repeat the suctioning until your airway is clear and provide breaks for the patient. So if I've suctioned once, I can put the oxygen back on, give them a minute to catch their breath. If I still hear that they need to be suctioned again, remove the oxygen and suction them again. That's not to say that if I've suctioned them for 5 times and they still have a lot of secretions, I can call for support, I can call for help. The respiratory therapists are always fantastic and can come help support us if we need. So that was suctioning a patient with an open circuit who was non-ventilated. For suctioning with an open circuit for a ventilated patient, the technique is pretty much still the same. Really, the only extra things you need to add is a blue pad or a PK or a towel over the patient's chest so that when you disconnect the ventilator, you place it there, and then the same technique applies to what I had just explained in terms of inserting the catheter, applying the continuous suctioning, and pulling out. It's important to try and sit the patient up in a semi-Fowler's position unless it's medically contraindicated. So it's nice to sit up. Hyperoxygenate the patient with 100% oxygen for 30 to 60 seconds if it's required. Again, you place that blue pad, a nice clean towel over the patient's chest so that when you disconnect, you put the circuit on that. Suction your patient, and of course, important to reconnect your patient back on the ventilator when you're finished suctioning the patient. So this is suctioning with a closed circuit, so inline for your ventilated patients. So a closed tracheal suctioning consists of a sterile suction catheter in a clear plastic sleeve. So you'll see with the numbers. So number 1, that's the mechanical circulation circuit. 2, the little thing that kind of comes out, that's an irrigation port. Then you have your flexible tube that's attached to the tracheostomy tube. In the other image, you'll see a more close-up of the inline suction catheter. So again, you have your rigid tip, the suction valve, that's the valve that you press down to apply the suction. You have your window for number 3, where you could visually see the secretions that you're suctioning out. Then you have your transparent protective sheath over top of the suction catheter. Again, number 6 in this image is your irrigation port. You also have your access valve, and number 8 is the T adapter that connects the circuit to the tracheostomy tube. So some advantages of having a closed circuit inline suctioning for a ventilated patient is the patient can still remain connected to the ventilator during suctioning. So they can maintain their tidal volume, oxygen concentration, and positive and expiratory pressure. In turn, this consistent connectivity reduces the occurrence of suction-induced hypoxemia. Because the catheter remains in a protective sleeve, the system also reduces the risk of infection even when you use the same catheter many times because it's a closed circuit. It also reduces the risk of spraying respiratory secretions, especially during suction-induced coughing, which is good in our COVID-19 times. And the irrigation port actually allows for clearing of your suction catheter. So you put the NS into your irrigation port on number 6, and you press the NS while simultaneously pressing your suction valve so that you're suctioning all the NS through your valve and you're clearing your suction catheter. So again, the technique is kind of the same, even though it's a closed circuit. So try to sit your patient in a semi-Fowler position unless it's medically contraindicated. You want to hyperoxygenate the patient with 100% oxygen for 30 to 60 seconds if required. And to do this, you can press the hyperoxygenate button or increase the baseline fraction of inspired oxygen level. For long-term ventilated patients, pre-oxygenating a patient prior to suctioning may not be necessary, so it's very important for you to understand and know your patient. So you steady the T-piece and insert the suction catheter. Then you apply the continuous suction while pulling back on your suction catheter for a max of 10 seconds again. And again, when you're cleaning, you squeeze that one-time use of NS into the port while pressing down on the suction so that you're clearing your catheter. So that was suctioning. So you usually would do that first, and then you can move into your tracheostoma cleaning. Why do we need to clean around the tracheostoma site? Obviously to promote healing. We do this twice a day, so every 12 hours and when needed. Some patients have a lot of secretions that we need to do it more often. Some tips, you're cleaning with NS and gauze. So basically how you would clean a PEG site or a wound, you're basically cleaning with NS, you dry around, and it's important to swab under the neck plate because you have your neck plate, and if you're just swabbing around it, you're not getting actually underneath right up to the tip of the tracheostoma because a lot of secretions and crust can accumulate under the trach plate. So you need to clean up and around there as well. You need to make sure that the site is kept dry. So if you have a patient with a lot of secretions, again, you may have to be changing that dressing a little more often. It's important to be aware of pressure injury. especially with mechanically ventilated patients too. With the weight of the vent pulling down on the trach tube, it can cause a lot of pressure on the skin underneath, which causes skin breakdown. So it's important to follow up with that. Again, your ventilatory tubes. So if there's a lot of pressure, you need to make sure that your vent tubes are supported. And finally, we wouldn't recommend, obviously, the use of hydrogen peroxide for the same reason you wouldn't use hydrogen peroxide when you're cleaning a feeding tube site. It doesn't promote any healing. It's also important when you're using a dressing that it's a pre-cut gauze, because if you were to take a regular gauze and cut it yourself, there could be loose fibers that will go into the patient's airway and could cause potential infection. So that was cleaning around the tracheostoma sites, and now we move into the inner cannula cleaning. So this is the cleaning for a reusable inner cannula. Again, we won't see this very often, but we do have some patients with a reusable. Why do we need to clean / change the inner cannula in general? Obviously to maintain patency. We usually do it again twice a day, so every 12 hours, and when needed. So this is when secretions or blood accumulate around the tracheostoma site. When there's excessive, secretions or blood that accumulate around, we want to change the inner cannula more often. So some tips when you have a reusable inner cannula: you have your tray, you put your NS in one container. In another container, you can put NS and a bit of hydrogen peroxide. Take out your inner cannula, put it in the hydrogen peroxide with the NS, and you can start scrubbing right away with your tracheal brush. Clean it in your other NS container. You can tap it dry and reinsert it back into the patient. We don't leave it to soak or anything. We start cleaning it right away. We don't wipe it dry because we find that thin film of NS actually will help ease the insertion of the inner cannula. So that's for a patient who's not on a mechanical ventilator. If your patient's on a mechanical ventilator, of course, you have to reconnect the patient back to the vent. So what do we do if a patient has a reusable inner cannula with a vented patient? So you disconnect the vent, you can put it on your pad, remove the reusable inner cannula, put it in your tray, but replace the inner cannula with a temporary disposable inner cannula so that you can reconnect your patient back to the vent during the time that you're cleaning your reusable inner cannula. Once you're done cleaning your reusable inner cannula, obviously you can disconnect the vent again, remove that temporary disposable inner cannula, throw it away, and put back your reusable inner cannula and connect back your patient to the vent. It's important too that if you can take vital signs, it's not necessary for a regular trach change. However, if you're doing an inner cannula cleaning because the patients have had some respiratory symptoms, then it's important for you to provide your thorough assessment and take the vital signs. An important note too is that there's no need to put the ventilator on standby, as there could be an increased risk of accidentally forgetting to turn it back on. So you don't need to touch the ventilatory settings when you're changing the inner cannula. So that's for the reusable inner cannula. If you're using a disposable, so for the disposable, it's fairly easy. You can pre-oxygenate the patient if they need, if they're known to desat when you disconnect them from the vent. So you can disconnect them from the ventilator, pinch the sides of the inner cannula, throw it out, put the new one right back in, and connect your patient back to the vent. Again, there's no need to put the ventilator on standby because it could increase the risk of forgetting to turn it back on. And it's important you need to insert the new inner cannula before reconnecting the patient back to the ventilator. There should be no patient who's connected onto a ventilator without an inner cannula present. And this is for safety reasons, of course. And I had previously mentioned, if there's a big mucus plug that blocks the tracheostomy tube, that inner cannula is a safety mechanism you can pull out and change, and the patient continues to have their patent airway. So that was cleaning or changing the inner cannula. We then need to move towards changing the neck ties. So why do we have to change the neck ties? Or what are the neck ties? What's the purpose of them? To keep the tracheostomy tube secure and in place. When do we change the neck ties? It's only as an as-needed basis, either when the Velcro is not functioning or not sticking properly, or when they're soiled. Otherwise, if we change it more often and we don't need to, we're just increasing the risk of an accidental decannulation. So some tips. It's always important to secure the new ties before removing the old ones, because if I remove the old ones before securing the new ones and the patient coughs in the meantime, the tracheostomy tube can fly out. I need to secure the new ties with a double knot, and that's if I'm using a trach tie the ribbon. However, I would recommend that if you see a patient with the regular ties, change them over to Velcro ties. It's a nice padded collar that's just much more comfortable for the patient, and you can see it in the image below. Always allow for 2-finger space between the neck and the tie. Always check this at the beginning of your shift too, because if the patient's lying down and let's say bed sheets were changed, sometimes the ties can actually become loose. And if the patient coughs, it could actually cause an accidental decannulation. So always make sure your trach ties are secure. It's important to assess the skin integrity, especially at the back of the neck too. A lot of patients, if they're sweating or whatnot, can start to have some breakdown at the back of their neck. You may need to consider a 2-person intervention. So if you have a very agitated patient, or even if the trach ties are very soiled, it's kind of impossible for you to put on new ones without soiling the new ones before removing the old ones. So just have someone come in, hold the tracheostomy tube while you remove the old ties, throw out the old ties, put on your new ones, and then that second person can stop holding the tracheostomy tube. It just provides a more secure way of changing them. And fastening the ties too tightly can lead to skin breakdown. So obviously that's why you have to make sure you only have 2 fingers. And vascular obstruction, and fastening them too loosely obviously can lead to the accidental decannulation. And this is our nursing intervention flow sheet. So we all have our nursing intervention sheets. This is actually a pre-printed one for us that describes all the care we need to perform for our tracheostomy patients. This is available on the intranet, so you can go there and print it out. And it goes for about 5 days, and again, everything is written out for you. So you need to document the tracheostomy tube. Which tube are you dealing with? What size is it? Disposable or reusable inner cannula? Is it cuffed? Is it cuffless? If it is the cuff inflated? Is it deflated? So all that basic information is written there for you. The stoma care, that you're cleaning the stoma, you're changing the dressing, cleaning or changing your inner cannula. The tie care, if we need to change the ties or if it's just intact. Trach suctioning, this is where you would document the time you're suctioning the patient and the amount of times you need to suction the patient. So it's a recto verso, so on the back side you'll see high humidity. You need to make sure high humidity is on at all times, so you would just sign off your check. Oral care we should be doing at a minimum of 3 times a day, and as needed, of course. If your patient has a speaking valve, you can document it here, the length of time they've used their speaking valve. Speaking valve care too. So just to clean your speaking valve, you can just use some soap and some warm water. And also we have the corking trial here. So if your patient will end up going on a corking trial, you can document it here. And I think someone else will give a presentation on that, but this is where you would be able to document the length of time that the patient needs the cork on. And then of course your post-decannulation dressing change. So when the patient passes the corking trial, we can take it off and put on a post-decannulation dressing. So you would sign it off here as well. So that concludes my module. Thank you very much.